Good evening to all present here for this webinar. This month, being Breast Cancer Awareness Month, Nurseslab presents to you the theme Every story is unique, every journey matters. We would like to introduce our speakers for this evening Dr. Sudhar A. Reddy, Mrs. Tina Pulikotil, and Mr. Abdul Razak. Our first speaker for this evening is Dr. Sudhar Reddy, Assistant Professor, Department of Nursing, University of Bisha, Saudi Arabia. Ma'am has completed her UG from College of Nursing, AFMC, Pune in 1992. Ma'am has completed her PG from KLE Institute of Nursing Sciences in OBG Nursing, Belgavi, 2000. MPhil from MCon, Manipal University, 2006. And PhD Nursing from National Consortium for PhD in Nursing, Rajiv Gandhi University of Health Sciences in 2014. Ma'am has been nominated of a member of Standing Regulation Committee of International Confederation of Midwives, ICM, for Southeast Asia. She's an adjunct professor at Thomas Jefferson University, Philadelphia, USA. She is also a master trainer for virtual capacity building program for midwifery faculty organized by INC, UNFPA, and also master training for helping babies breathe program. Ma'am has organized many national and international conferences and workshops, and she has a total of 32 international and 17 national publications in her credit. We welcome you, ma'am, and over to you.
Good evening, everybody. As we all celebrate the Breast Cancer Awareness Week throughout the world, so we all know we have been participating in so many different kinds of activities and doing our own small little role in spreading awareness about breast cancer and its prevention. Hope my slides are visible. And I thank Nurseslab and Alvin sir and all others for giving me this opportunity to be able to present again. I hope my slides are visible. And today we talk about screening saves lives, breast cancer, demystifying, and the role of early detection. So just a little bit, we will hurry up about how does a breast structure look like, what is it, what are the causes, stages, facts, symptoms, and then we will focus more on screening and early detection. So breast cancer is it's a primarily fat and breast tissue and a very complex network of lobules, lobes, and ducts. And usually it performs the main function is breastfeeding. And many breast changes will occur over a woman's life due to hormonal changes, and most of these are benign, so nothing to worry about. But when we come to breast cancer is a disease where abnormal breast cells divide and grow out of control and they start forming tumors. There are different types of breast cancers which all depend upon the types of cells which have turned into tumor, and breast cancers can also spread to other organs and areas in the body. And if someone asks or tries to, ponder why breast cancer, why does it happen? It's all gene mutations, hormones, and other risk factors. Only 10% of breast cancers are inherited, and most are suddenly, without any reason, there are spontaneous gene mutations. And the most famous and inherited genes which are related to breast cancer are BRCA1 and BRCA2. So if you look at the different images, just to have a quick recap, stage 0, you just have the breast tissue getting tense, and in stage 1, you find one lump. In stage 2, there's the lump growing in size and spreading to the lymph nodes. Stage 3, you have multiple lumps spreading across the lymphatic system. And stage 4, it has metastasized to other vital organs in the body. And as we all know, like it's the leading cancer among women worldwide. And the latest statistics which I have from 2022, 2.3 million women were diagnosed. 6,70,000 is the breast cancer death rate worldwide. 99% occur in women, and of course, 0.5 to 1% occur in men too. And every 15 seconds, there's a one woman around the world diagnosed with breast cancer. Every 50 seconds, as we talk now, a woman dies of breast cancer. And there are modifiable and non-modifiable life risk factors, lifestyle factors, which can be modified. Like never having children or having your first child poses a problem. Currently or recently, if you have used combined estrogen and progesterone hormones, or that is the HRT therapy, if your current or recent use of birth control pills, if you're not breastfeeding, a diet rich in fat or red meat, especially poor in fiber and fruits, and physical inactivity and overweight or obesity, and of course, smoking and drinking alcohol. These are the modifiable risk factors. And the non modifying risk factors, of course, being a woman, like we can't do anything about it, we are more prone, getting old. And if we have an inherited mutation in the form of BRCA1 or BRCA2 genes. These are the breast cancer genes specific to breast cancer. If you have a family history of breast cancer, or you have had a previous personal history of breast or ovarian cancer, if you have very dense breast tissue, or you have a previous biopsy showing hyperplasia or carcinoma in situ, this become the risk factors. So if the breasts look this way, or when you as a healthcare provider or a nurse do breast cancer awareness camps, and if you see this is the way, these are the changes you find in the breast, please, hardening of the breast, puckering of the breast, erosion of the skin around the breast, redness here, strange fluid coming out of the nipple, dimpling, bump, growing veins. You see prominent veins over the breast here. The nipples are retracted. Suddenly, a new kind of asymmetry your breast finds itself in, and then the orange peel, skin appearance, and lumps inside. So, if you see any of these changes, it's time for you to quickly go meet your doctor. Most people will not experience any symptoms when cancer is still early. Hence, there is really a question of doing early detection and getting into it. It has a combination of symptoms, especially when it is more advanced, which can be a breast lump or thickening of one without a pain, change in the size, shape, or appearance of the breast, dimpling, redness, pitting, or other changes, change in the nipple appearance or the skin around the nipple, abnormal or bloody fluid coming out of the nipple, and people with an abnormal breast lump should seek immediate care even if the lump does not hurt. Most breast lumps are not cancer. Many of the young girls will have fibroadenomas of the breast. So the lumps which are cancerous are more likely to be successfully treated when they are small and have not spread to the nearby lymph nodes. So these are some of the basic simple facts which we just thought would go across before coming to screening. And if you adopt a healthy lifestyle, definitely we can prevent breast cancer. Do breastfeed. You have had a baby, please breastfeed. Have a healthy diet, quit smoking, avoid hormones as much as possible, and regular exercises is the key mantra. Now we come to main topic here, screening and early detection. So when you try to do screening and early detection, what is it all about? You can do breast self examination, which is called BSA, or breast self awareness. You can go in for a clinical breast examination and, of course, mammography. So, what is it about breast self examination? Where you know your own body, you do the self examination on a monthly basis after the menstrual cycle. From the age of 20 years, every month you have to do it. And when you go to a hospital, you do a clinical breast examination every 3 years at least, starting from the age of 20 years, and then every year starting from the age of 40 years. That means you need to go to a healthcare professional, ask them to do it for you. Sometimes some small lumps, nodes, lymph nodes can be missed by us. So it's good, like, we go and get it done. And mammography, all women age 40 and above should undertake a screening mammogram every 2 years. I'm giving you this talk, but I have never got a mammography done. And recently we had a breast cancer awareness camp in our hospital here. Me and my colleague, Dr. Bhuvaneshwari, we were responsible. We went with the students, and then we were scanning those questionnaires. And then there was a performer which asked, "Have you undergone a mammogram?" Then I tick mark, no. So, they took my mobile number, my national ID number, and they will be calling me back, giving me an appointment for a free mammography. Why I give you this example is all of them who are above 40, if you have never done it, please go, think of me and just go and get it done once. Get yourself screened for mammography. Uh, Today, one of our colleagues is going to speak about men and breast cancer. But this slide is about men and breast cancer, because men has an important role to encourage the woman in their family to go and examine themselves to make sure that the incidence of breast cancer is prevented. Women feel shy to go, so the husband says, "No, no, let's go. Let's have a checkup." It matters a lot. And remember that this breast cancer is a disease that affects the whole family, and the support for the women is very important and needed. Of course, breast cancer affects men, but very rare. For every 100 diagnosed women, one man is diagnosed with breast cancer. Same like women, and it should be immediate if any of those symptoms are seen. Now, coming to mammography, the cornerstone. This is the digital X-ray of the breast. It detects tumors 2 to 3 years, even before it gets palpable, even before you can palpate a lump or a nodule in your breast or axilla, you can feel the starting of breast cancer 2 to 3 years before that. Early calcifications are seen. It's very safe, low radiation, simple X-ray of the breast. And clinical breast examination, when we advise you to go for, please go to a nurse or a physician. They will inspect and palpate the breast and axilla, and they will detect lumps, discharge, or asymmetry if you miss out or if you're not able to find it. Now, when we talk for self check, the self breast awareness, four things you remember: look, raise arms, feel, and check underarm. So you look in the mirror for inspection, raise your arms, wait and observe for a moment. And do you feel that is your visual inspection of the breast with the arms in different positions? What do you feel? Do they look symmetrical? Suddenly, there's a change in the symmetry of a breast. There's some dimpling, some puckering. The nipple is retracting, and suddenly you feel that you have some kind of eczema in winter over your nipples, and you have a lot of itching. So, that's also an important sign. Sometimes in some women in Paget's disease, the nipple starts eroding and it disappears because of the underlying carcinomas. It's very important. The simple phenomenon of standing in front of a mirror and looking at your breast, doing a visual inspection with the arms in different positions, raise your arms, observe for movements, feel the circular palpation and feel for lumps. And what are the things you need to watch for? Lumps or thickening, changes in the shape of skin, nipple inversion or discharge, and persistent pain. This is one example of Paget's disease. I'll not go into much detail because of time lag. This is how the nipple becomes eczematous. It starts disappearing in its structure. You can see the arrow where I'm showing you. And this is a sign of underlying breast cancer if not treated. This nipple eczema. They take it for biopsy and test it and confirm. And these are the clinical presentations of different kinds of breast cancers. This is the POD orange of the breast, where there's puckering of the breast and the peeling. You can see these pigments, like the orange skin has those taka pigments, pits like that it looks. And then you have this POD orange, and then when it goes further, it is cancer encurase, where the disease progresses around the chest wall. It's too late, you know, and difficult for it to be cured. Then, what are the barriers? Why we all not go for screening? Because of fear, lack of awareness, access, whom to go. There's a male doctor, how will I go and show him? All those things. Solutions are more education, counseling, and free screening. If you go and do frequently, they will come to you on their own. So this is another diagram where by looking, by touching, while lying down, there are different ways where you can do. And by looking, I have told you before, put your hands in different positions in front of you, beside your body, keeping your hands on your hips, keeping it behind your head, and trying to look at the shape and symmetry of both breasts in this. By touching, you raise one arm, use the pads of your 3 or 4 fingers of the right hand to examine your left breast, and vice versa. So you try to check in circles. One is like you go up and down. Once you try to check it in circles or divide your breast into wedges and just examine it in that way. Of course, while lying down, if you have some doubt, lie down, keep a pillow under the axilla on one side and try to examine and look for lumps. And if you feel an enlarged lymph node, it will feel like a corn kernel or a bean. So if you feel it, don't be afraid. Go and show yourself. These are the other ways. Another picture where it shows you how to do a breast examination once a month, 7 to 10 days after your periods. And if you're not menstruating, if you're in your menopause, pick up any date. Then this is by raising your arms. This is for looking for any physical changes, that's lumps or swellings, redness or rash. Here you are gently squeezing the nipple for any discharge to come out. Here you go to the tail of the breast and try to check whether there are any lymph nodes hidden in the armpits. Then when you check the breast, you can start at the outer edge and move towards the nipple slowly and cover as small sections at a time as you can. Do the same with moving your fingertips up and down, then in round movements like in this picture, and then do the same step when you're lying down also if you have any doubt. If you have any questions, any doubts, you feel there is something, please go to the doctor, do a mammography annually after 40 and take care of breasts. In case you undergo a breast surgery, nothing to fear. Pre and post-op care is there, lymphedema prevention is there, a lot of psychosocial support, counseling is there, and then more of self-breast examination and education will guide you for further advancement in the disease. The takeaway message from today's presentation is remember, if a change is found, it's very harmless, but still you need to be checked. Don't ignore them. A doctor has to determine if there's a problem, and regular checkup and early detection will save lives. Thank you so much. And if there are any questions, we'll take them. Thank you.
Thank you, ma'am, for that brief but interactive session. I request the participants, if they have any queries, to type the query in the chat box, and the speakers will be answering them towards the end. Our next speaker for this evening is Mrs. Tina Pulikotil, lactation consultant practicing in Dubai, UAE. Ma'am has completed her BSc in Sri Raghavendra College of Nursing, Bangalore, and Masters in Healthcare Management from Swiss Business School, Al Tariqa Management Studies, Dubai, UAE. Ma'am is a certified CPHQ and International Board of Lactation Consultant Examiners. Currently, ma'am is practicing and rendering services as a board certification lactation consultant and actively participates as a speaker and trainer in service education. We welcome you, ma'am. Over to you.
Good evening, all. Thanks for the warm introduction. And I would like to convey my sincere gratitude towards the Nurseslab and their organizers for conducting such breast cancer awareness program. And really, I'm thankful for the attendees who are been participating here, because this shows a commitment towards our breastfeeding breast cancer awareness campaign. And who anybody who is there in this audience who has have being caregivers or survivors, I really appreciate them for their strength and resilience. So today, the topic which I have taken is breastfeeding and breast cancer. So, as we all know that, and I would like to take a moment to thank Dr. Sudha for the wonderful sessions. And a few of those points, it's really coming up in my topic, definitely. So, let's go with that. So, breast cancer, as we all know, that is the most common malignancy among women. As per the US Cancer Statistics Working Group in 2007, about 1/4 of all women receiving diagnosis of breast cancer are premenopausal and are potentially in the age of the fertile period. So, breast cancer in lactating women. So let's see that breast cancer in lactating women is a clinical issue, definitely. New technology detects tiny precancerous calcifications that require further investigations. So, as Dr. Sudha has said, definitely we do have modified factors of breast cancer and non-modified factors. So let's see and find out whether the breastfeeding is a modifiable factor of prevention. So breastfeeding is one of the few potentially modifiable factors that help to prevent breast cancer. So there has been initially so many studies has been conducted. So one of the breakthrough was in the meta-analysis which was conducted in 2002 by Bernier. They had a collaborative group on hormonal factors in breast cancer. So they found out that on this has been an effect of breastfeeding on the development of breast cancer, concluded that breastfeeding provides a protective function against breast cancer. So, on the estimates obtained from the collaborative group on hormonal factors in breast cancer 2002, it was found that women in developed countries, those who has an average children of 2.5, if they breastfeed for more than 6 months at a longer age, they have 5% breast cancers will be prevented each year, and it increases to 11% of breast cancers might be prevented yearly for if they have breastfed an additional of 12 months. So there have been inverse association between breastfeeding and breast cancer. That these are the studies which were by Young et al. In 1996, Newcomb in 2001 in UK. They found that breastfeed for a longer time have an inverse associations. Those women in premenopausal age also has an inverse association, and those women who has a birth at an early age. So these are the again a few of the studies which has to be addressed. In 1977, the women in fishing villages of Hong Kong found that four-fold increased risk of cancer in unsuckled breast. So what this study was included was there was a customized practice of women in a fishing village to breastfeed only the right breast. So they will not particularly they purposefully they will not breastfeed a particular breast, either the left or the rest, or the right or the left. So what happens here? They found after the studies that wherever the baby has not suckled, that breast was fourfold at the risk of developing breast cancers. And these are the subsequent studies which was given the evidence, provided evidence of the association between lifestyle, religious value systems, and risk factors for breast cancer, which was conducted in US among the non-Hispanic white females and LDS from Utah. So detection of breast cancer during pregnancy and lactation, it's quite emotionally and physically, it's a challenging and accepting for everyone, including a woman and to their family. So pregnancy-associated breast cancer can be defined and that breast cancer diagnosed during the pregnancy and a period which is from the occurs in about 1 in 3,000 pregnancies. So it will be a period between 1 year of between the pregnancy and the childbirth of 1 year. So it occurs in about 1 in 3,000 pregnancies as per the American Cancer Society in 2008. So advanced, and this being advanced at time of diagnosis and estrogen receptor negative, but carry a similar prognosis to other breast cancers when matched for the stage and age. So challenges in detecting breast cancer during pregnancy and lactation is increased density, glandularity. So this is in the right hand side, you can see the basic structure of a breast pretty well. We all will be knowing. So we have to know each parts, their role during the lactation, during the pregnancy, the completion of the complete course of pregnancy, then to the childbirth, lactations. So every stage of the pregnancy and the lactation, there are changes happening to the ductal and the breast tissues and the ductary systems. So you can see the areola, lactiferous sinuses, lactiferous duct, breast lobule, and the ligaments and the muscles supporting that. So increased density, granularity, and water content of the lactating breast delay the diagnosis. So sensitivity of a conventional mammography. In a review of past research, it was conducted in 2003. So Young et al. In 2006, they came out that despite of the density of the breast showed the improvement in tumor detections. And in 2005, the magnetic MRI is useful in detecting breast carcinoma in the lactating woman. So in clinical practice view, how we will be referring those lactating mother to a physician. So there are certain criteria. So being a lactation consultant or a multidisciplinary approach, we have certain criteria when we will refer those lactating women to a physician. So the criteria starts with any mass that shows no decrease in size after 72 hours of treatment. So basically those lactating women comes with the complaints of blocked ducts or to a complications which reached a stage of mastitis. So what will be the initial line of diagnosis and management will be initiated for that woman. So first is any mass that shows no decreases. Usually we know that there is a physiological engorgement happening to which leads to a pathological engorgement. So any mass or that will not show any decrease in size after 72 hours of any treatment or intervention. That is the first thing. Then the second is a febrile mastitis. So if like symptoms that are prevailed after a course of antibiotics. So it will even after the course of antibiotics, if that mastitis persists, and recurrent mastitis or plugged duct that appear at the same locations. So once a patient came, or a lactating mother came to us with the complaints of plugged ducts, we treated. It could be a simple insertions or with the interventions which can be relieved as a common course of action. But if that mother is coming again and again with the same complaints and with the mastitis, then that's the time we have to refer. So the reference goes with if our facility is with a lactation consultant or a person who is a dedicated or a certified lactation consultant is there, definitely that person will be given a notification and will be seen in the postnatal and postnatal. Then from the lactation consultant to the physician, that will be an obstetricians or the team of physicians seeing the patient, and then that escalation will goes to next to the surgeon. This will be the scale of escalation. So definitely there are myths about breastfeeding when it comes to breastfeeding. So the first and foremost will be, can the baby receive the cancer causing viral particles in human milk? So the studies say that no evidence that breastfeeding after treatment for breast cancer carries any health risk towards the baby. So neither an increase or decrease in incidence of breast cancer in breastfed daughters of women have had been a breast cancer. So even if we know that there are some certain myths and beliefs when a lactating woman getting with any infections like common flu or fever or a seasonal infections, even into the remote, there are certain beliefs, cultural practices that not to breastfeed the child. Oh no, now mother is having infections, then infection will be spread. So definitely the basic management, say if we all know that when we are with the signs of infection, definitely there are fighting, something is fighting against our body, and that is creating an immunity in a human being. So definitely that benefit is going to whom? To the baby through the breast milk. So that myths is everywhere when it concerned with the breastfeeding. So special consideration for breastfeeding who develop cancer during lactation. Yes, using imaging hold, a mammogram is the basic imaging screening technique, and biopsy. So there are certain consideration to be made when we are considering those patients for biopsy. That is, the breast should be emptied. Why? Because if not emptied and biopsy needle is passed for the particular screening, it will cause a milk fistula. That's it, that there will be abnormal opening between the tissues and there will be leaking of milk towards the tissue. So what we have to do, we have to encourage the lactating mother to empty her breast or use ice packs or a binding or a lactation suppression medications to suppress her milk supply. If there is a positive diagnosis for a breastfeeding woman, then the foremost step should be interrupt the feeding and to begin the treatment. Chemotherapy, during the chemotherapy period, definitely not to breastfeed. Chemo drugs are anti-metabolites crossed into the milk, and it is toxic to the infant. So lactation following breast cancer, women who have undergone treatment like surgery, radiation, chemotherapy, there is no little or like the milk producing capacity of the woman is not going to like very merely it's going to affect the lactation capacity of a woman, but definitely it is some more or the less it is going to affect the elasticity of the breast tissue during the lactation. So the treated breast likely to have a full milk supply and possible absence of lactation. Lactation is not going to there is not going to have a complete absence of lactation, but what is going to we need to have, say that the surgery is affecting the ductary system, where from the lobules the milk has been carried through the ducts and to the baby. So if any surgery is involving a major part of the ductary system, definitely there will be a compromise, but there is not merely of complete absence of lactations, but the unaffected breast can completely have a full lactation capacity. So difficult with latch on, yes, that can be seen because the breast may not extend as completely. Concerns of women who have experienced breast cancer, yes, definitely fears of recurrence of cancer, conflict with women's desire to be a good mother. Yes, this is what we are initially telling, that becoming a pregnant, bringing the baby to the world, it's a complex thing where a woman requires a common support from her. So fear of recurrence is one of the concerns of a woman who is going through the stage. And psychosocial issues related to the fertility, definitely contraceptive choices, pregnancy and breastfeeding following a breast cancer. So definitely this so all the special cases including this breast cancers should have a one-to-one counseling, one-to-one supportive sessions for the woman as well as her family, to understand the course of treatment and further how they can bring their fertility life. How does breastfeeding reduce the risk of breast cancer? See, we can see, as we explain, the stages of lactations goes through three main stages. That is development of breast, the mammogenesis, lactogenesis, and galactopoiesis. Mammogenesis, development of the breast. Lactogenesis means the milk production. Galactopoiesis means the maintenance of lactations. So these stages are affected by hormonal changes, immune system shifts during breastfeeding, and changes in breast tissues. So initially what happens during the pregnancy till the birth, it will be an endocrine control or hormonal control. Once after the parturition of the birth, what happens, the progesterone will be there until the birth. Soon after the delivery of the newborn, parturition happens, the progesterone level starts going down, and it eventually the lactation will be under the control of autocrine control. So these are the main cause which will lead to the lactation. So long-standing research, what it has consistently showed that breastfeeding can reduce the risk of breast cancer. This includes a 2002 report in the prestigious Journal of Lancet, which evaluated data across 47 epidemiological studies on more than 50,000 women with breast cancer and nearly 1 lakh women without the disease. It was found that the relative risk of breast cancer declined by 4 to 3% for every 12 months a woman breastfeed. So, and also we can see a 2013 meta-analysis in the Asia Pacific Journal of Public Health found a similar relationship between the breastfeeding and the breast cancer. And this association is so strong that Lancet report in 2016 that the current rates of breastfeeding directly prevent nearly 20,000 of deaths from the breast cancer every year. An additional of 20,000 lives will be saved annually by scaling up breastfeeding practices worldwide. So that means, that being said, the breastfeeding seems to have a stronger protective effect on some types of breast cancers. And here, so when sharing a common thought here, what we can do, the healthcare facilities, the simple foremost steps we can do that to have a baby-friendly hospital initiative, where in which hospital where the maternity and newborn care has been rendered. So these gave a simple, successful steps how a woman can go to a successful breastfeeding, which in turn helps, which in turn is a modifiable factor which can reduce the occurrence and of breast cancer and the death related to the breast cancers in the pregnant and lactating woman and the common layman. Thank you so much. If any doubts or questions can be carried out at the end.
Thank you, ma'am, for that very detailed session. Our next speaker and the last speaker for this evening is Mr. Abdul Dayan Razak. Sir is currently working as an AGM, Nursing Operations and Quality Corporate Officer, Healthcare Global Enterprises Limited, India. Sir has completed his BSc Nursing from RGUHS Bangalore, postgraduate diploma in medical law and ethics from Annamala University, Tamil Nadu, His Master of Science in Oncology Nursing from Dr. MGR Medical University, Chennai. Sir has also a master's degree in business administration, certificate in palliative care, MSc degree in medical sociology, and postgraduate diploma in total quality management. With over 13 years of experience in the field, Sir has worked as an internal assessor for NABH and Nursing Excellence, National Faculty for CAHO, Hospital Quality Program, Director of Nursing Quality Improvement. Sir has been awarded Best Teacher Award, Best Oncology Nurse, Best Nurse Excellence Award from HCGEL, and National Young Quality Achiever Award in 2024 by CAHO. Sir has been invited as a speaker on international, national, and state level forums on nursing quality and healthcare conferences. We welcome you, sir. Over to you.
Happy evening, all. Just give me a moment. I'm trying to pull the slide. Okay, so I guess we are in a very important month discussing about breast cancer, and definitely, we also had to hear from the first speaker who was trying to speak about breast cancer in women, which is a very commonest, cancers, I would say, because I work for an standalone oncology hospital, of India, and we are 27 centers across India, and we see left and right breast cancer, women walking into our organization at any part of center of across India. So probably the lifestyles, probably the the mutations or whatever things happen. The same thing is also seen among men nowadays. We are seeing few cases. I wouldn't say it's equally proportionate or equally kind of 50-50 or something like that. Probably I could say the ratio or walk-in of a men with symptoms of breast cancer is very few, minuscule, but still we are slowly having these reports. Slowly we are trying to have reports of men coming forward and trying to talk about tenderness over the breast, and some discharges in the nipples, inverted nipples. So there are lots of other symptoms which are slowly being reported. Probably we are breaking those silence. I think so. Thanks to Nurseslab, and Albin, my colleague who was associated with the former organization now, who's become a very good friend of mine. Thanks for having me on this particular session and choosing this topic right, men and breast cancer, breaking the silence. So with this particular intro, if you ask breast cancer in men, is it possible, or do we ever have heard about this particular problem? Yes, we would say we have to shout out loud now, saying that yes, there are people, or there are reports of men coming and reporting of breast cancer. We would definitely say it is rare, but slowly it is kind of getting reported. Probably awareness is slowly coming up, or the advancement of healthcare, the advancement of innovative technologies to rule out these particular conditions are slowly coming up, and it's booming. So early detection is also happening. So just to speak about the male anatomy, I guess the former speaker has already spoken about. I'm not going to take much, but only difference in male breast versus female breast. We all know male breast is very rudimentary; it is not completely developed, and only thing is, the male breast doesn't have lobes. Okay, so most of the thing when we look into the breast cancer or CA breast among women and the men, most of the time is lobular cancers are very common in females, and ductal carcinomas are also common. But when you look into men, the men anatomy don't have lobes. It's only a ducts we have. So slowly the ducts sometimes get kind of blocked, or some sort of an infection or inflammation leading to this, or it can be overall the changes in the gene pattern also. So looking into prevalence, so probably if you're trying to talk about, okay, what is the range, or what is the ratio of breast cancer across the world? If you look into it, including India, the reports are 0.5 to 1% roughly, but still we are not very, very clear with what is the number. And I have one more incidence to talk about, which has come out from India, where the Cancer Registry Program of India, I would proudly say that we were, HCG was also part of this particular Cancer Registry Program, which was conducted during the year of 2022, and they projected out of 2025 what would be the risk. So we look into the risk, Among crude incident rate CR, we were seeing 0.8, and age adjusted rate was almost around the same 0.8, and cumulative risk was something around 1 in 1,000 and 1,000 odd men, right? So this is kind of alarming. Probably though the number or though ratio is very minuscule, say that 1 in 1,000 men. Probably we're just calculating about overall men across India, and probably we are going to have a alarming slow rise of cancer incidences among men also. Equivalent is going to be somewhere touching between something around 10 to 15, where we're trying to talk about penile cancers and testicular cancers also, right? So that is how the balance is going up now. So apart from this, we look into the international standards or international, prevalence. We are seeing, the incident rate overall is 0.5 to 2.1, which has been given by Globocan 2020, which is again published in Lancet 2025. And they also say approximately US new MBS cases, that is men breast cancer cases, they say approximately 2,800 men kind of were affected. So these are the various reports which is coming out from a very standard publications which say these were the reports, probably because the most of the time it is all about men are not kind of reporting ahead, so that probably certain time the cases were also missed. We are not very sure, but overall these were the cases which has been kind of published. So we could say the diagnosis or the median age for when the men is getting diagnosed between 60 to 70, but we could say certain times it is also this 60 to 70 years of this the frequency is also made a little bit false. We also have seen cases at HCG, very particular. We have seen patients coming and reporting the age was, the earliest age was 52 for us, where we saw a 52 years men coming and reporting of CA breast. So probably here and there varied reasons are there. Looking into risk factors, we always say there are multiple factors because we don't have a direct cause for cancers, we all know. But in men, what can be the commonest risk factors? Probably not a directly linked cause, but what can be the risk factors? The first thing is genetic. We have already spoken the same thing when we try to talk about breast, either in men or in women. BRCA gene is one which is very, very important, and the mutation towards this BRCA2 or BRCA1 mutation, it will lead into the exact diagnosis called CA breast. Sometimes it can be also Klinefelter syndrome, because we all know when we look into this Klinefelter syndrome, the men or the individual kid or growing up adolescent will definitely have this particular presentation of a developed breast or a slowly developing breast, because of those karyotypic changes which is there, because the dominance of the gene is like, or the chromosome is XXY rather than having X and Y. So or YY. So basically, those are the reasons why we also say that if at all Klinefelter syndrome, and nowadays there are also few reports, but it is not reported as in scientifically. So I have not presented here. Even a slow study rate of men coming and reporting gynecomastia are also having a linked association with CA breast, but it's not very sure because it is not anyways published anyway. So we are not taking that as a reason, but it's just an overall understanding, overall clinical presentations, how a patient come and report to us. Apart from this family history, I guess thanks to Madam Sudha, who was trying to talk about the importance of men, being as a shadow, being a partner, making a female or making a wife or a spouse or a mother or a sister or whoever it is, a role, whatever a man is playing with any sort of a relationship there in a family, to allow this female or to encourage a female to go and get reported. Along with that, it is also very important that a man has also to remember men has equal incident rate when a family, a first degree relative is affected with a breast or ovarian cancer. Basically, we try to talk about hormonal cancers. Okay, so in cancers, we are trying to divide to blood disk solid organ tumors and the hormone related cancers, where we are trying to talk about hormonal related are ovarian cancers, breast cancers, testicular cancers. So all those things, when a first relative or a first degree relative, a mother or a elder sibling or a younger sibling, someone has been affected with a CA breast, probably a man is also having some degree of incidences or some degree of prevalence in his gene where he can be having a chance. Apart from this endocrine or hormonal, probably we talk about hyperestrogenism, probably much amount of estrogen production rather than having an androgen or something like that, a male hormone. Androgen deficiency, testicular disorders, probably orchitis or trauma, orchidectomy. Sometimes when a testis has been removed for some reason, probably in a young age, when a kid is having a testicular torsion or something, and orchidectomy has been performed, a kid doesn't have a testis, or it's just with a single testis and androgen is not being able to produce, or a male hormone is lacking there, probably this particular kid, when he grows up, definitely there is the incidence or a chance of getting diagnosed with a CA breast. So apart from this prolonged estrogen exposure, such as a prostate cancer treatment, sometimes when you try to give receptors, or we try to give hormonal treatment, so even a longer time of exposure can also be one of the reasons. That's how it has been related. Apart from this occupational environment, high temperature work, probably people working in all these industries, and radiation exposures, then lifestyle, obesity, alcohol consumption, sedentary lifestyle, and all those things, and medical conditions like liver cirrhosis, pituitary adenoma, and etc. Because in pituitary adenoma, what happens is the increased prolactin is produced. So because of that, there are chances of having a slow open door for this particular instances also. And age above 60 years, probably, as I already told you, 60 years is kind of an age which has been displayed, but there are also cases which has been reported. Okay, coming down to symptoms, or what might be the symptoms, because men do not have actually a developed breast. What might be the symptoms? Basically, lump or swelling. So most of the time, what happens is the patient reporting to a hospital with such presentations are very, very rare. The reason is, as the breast is not developed completely, so what happens is it's just a kind of a small piece of a muscle which is stuck onto your chest wall. So the men do not give much concentration towards the chest wall. So basically, until and unless they are very keen on the body, probably it is also a basic men's ideology or mentality where we don't concentrate much on our looks. Nowadays, off late, slowly we started concentrating little much, but not as females are taking care. But even in females, most of the time, working women and lots of areas where female also neglect basic this particular understanding of the body. So when you try to talk about a lump or swelling is one, nipple retractions, nipple discharge, skin changes, nipple or breast pain, rash or ulcer, changes in the breast size or the shape, probably one chest or the breast being larger with the other one in comparison, swollen or lymph nodes, probably like in cervical lymph nodes or an axillary lymph node, some sort of a lymph nodes which has been presented, but most of the time it has never been kind of palpated or it has never been examined. Then skin texture change, orange peel, breast cancer comes with, there was images which madam also tried projecting on the screen. A beautiful orange peel presentation is a very beautiful diagnostic tool for CA breast. Many of the time when women come in to our clinics to get diagnosed, we can see this beautiful orange peel texture which has that kind of a wrinkle over, lots of dots, lots of pitted dots on that particular breast tissue or the skin. So it's a beautiful presentation. The same thing may happen even with the men also, breast thickening. So these are the basic symptoms what we are trying to say. So how do we detect? So all thanks to all this technology, how it has been taken up. So clinical breast examination, probably now, slowly off late, even at HCG, the organization where I come from, we have also started, self breast examination awareness program for men also. Earlier, concentration was only with the female. We try to walk into the OPD, our nurse navigators who try to help patients learn this particular skills of actually palpating and then trying to understand what is wrong. We also have one self-examination room which has been placed so that the nurses down there, they try helping up. So now what we have done is we have also appointed few male nurse navigators who are trying to help men in doing the self examination or training them, and kind of making them understand how do you actually palpate the breast and how do you actually do a testicular examination. So we have added this also now. Apart from this, mammogram is one, ultrasound is one, and magnetic resonance imaging or something called as an MRI. And if at all there is a lump, there is an kind of an ulcer, there's a kind of some discharge or something like that, or an evident mass sitting down the skin, probably we can also go for a biopsy. It can be a fine needle biopsy, or it can be a punch, probably we want to do it. Or apart from this, it can be genetic testing. We want to know whether the BRCA has been having a mutation, so probably there are lots of tests which helps us. A genetic genomic test can be also taken. That depends again how much the patient is affordable, because gene testing, usually the panels are more costlier, so we have to look into like what are the gene panels which is getting covered and how much we are trying to do and what is the cost involved, whether the patient is also affordable. Apart from this, advanced imaging like CT or bone scan, probably we are trying to talk about CT, or to understand whether the patient is having sometimes a skeletal mets, because the breast tissues are very much closer to the rib. So the patient don't present with CA breast, or they are not actually diagnosed on an early stage. The patient most of the time they come and present with kind of too much of arthralgia, too much of overall malaise, overall kind of a pain over joint and the bones, and then we slowly rule out that the patient has already gotten bone or a skeletal mets. So this can also be one of the reason where we are using a bone scan or a SPECT, a single a positive electron computerized tomography for the direction also. So it can vary from the diagnosis pattern also. So apart from this, we are trying to talk about the treatment. We are trying to, again, the same thing, how a female breast cancer has been evaluated or been treated or staged the same way. Here also the men breast has also been staged for the disease. We have stage 1 and stage 2, stage 3 and stage 4. So basically stage 1 are called to be a localized or early stages, where we are trying to understand with an early assessment and all those things. Then probably if we require the surgery has to be performed, probably a modified radical mastectomy has to be performed, but not much amount of body image disturbance. We could definitely say the reason is the men do not have much amount of changes in that. So apart from this, if at all there are any axillary nodes or any left out nodes which have been there, even those particular things have been removed. But only problem is, again, the lymph edema is again a challenge. Likewise for the female, even in the men, the lymph edema becomes a little bit of a challenge, and it also interferes with their daily living or daily work, office going and all those things. So apart from this, what are the other things we try to see is adjuvant therapy. Probably we speak about radiation, chemotherapy based on the stage, or hormonal therapy. So basically hormonal therapy plays a very major role than the chemotherapy in breast cancers, because these are considered to be as a hormone related cancers. Basically we look into 3 basic tests. One is called PR, that is estrogen receptor, progesterone receptor, and HER2 receptors. So if you are understanding whether the patient has been put for this particular blood test also, if the patient is becoming positive for ER positive, PR positive, HER2 positive, then obviously it's going to be an kind of a hormonal therapy, or it is negative, either ER negative, PR positive, and a combination of HER2 negative or positive. Again, hormonal therapy has been put. So that depends on what type of a role the hormone is playing in a men's body. Based on that, hormonal therapy is also been tried to give it. So apart from this, if you're trying to talk about stage 3, a locally advanced, probably it does not spread where there's no, kind of spread towards a bone or something like that, but it's just on the breast tissues. Then we try to talk about neoadjuvant therapy, which means what? Chemotherapy given, and then we either go for a surgical management or go for a radiation therapy. That's why it's called as neoadjuvant. Or we also go with chemotherapy plus or minus of targeted therapies. Also, targeted therapies are nothing but which are very specific drugs which can target that particular cell alone. So apart from this, we also go for adjuvant radiotherapy along with plus or minus of hormonal therapy. So that depends on the decision of the tumor board or the cancer review board. Basically, I'm sure that everybody is aware a cancer treatment is not planned by an individual medical oncologist. It's a team of medical oncologists who make a decision on a care protocol for a patient. So it is worldwide. Obviously, it is not an isolated consultants who make a decisions. Obviously, it's a collective suggestion taken by all the specialists coming together, the medical oncologist, surgical radiation oncologist, sometimes even the interventional radiologist comes in, and sometimes even an audition comes in, depending on which organ it is affected. So obviously audition has been taking a main role here, because being a breast, so obviously we have all these particular people to discuss and then understand what is better for a patient to take up. So coming to stage 3, that is, stage 4, that is called metastatic, where a person is diagnosed or a patient reaches a hospital very late and his particular diagnosis has been made very, very late, and he is already having an advanced disease where his bone has been already having a problem, where his rib or the skeletal bone has been taken toll on that particular condition. In that case, we speak about hormonal therapy, we speak about chemotherapy, we speak about targeted therapy and bisphosphonates. Bisphosphonates are nothing but the potassium, or we are trying to talk about the supplements like phosphorus and the calcium, which has been given in a form of an IV to strengthen the bone, because the bone is more fragile. It's like already getting faded up. So most of the blastic activity and clastic activity happens there. So to give little bit of a strength, we give this IV bisphosphonates or IV calcium therapy, or phosphorus therapy is being given. So that is basically it can be for any disease, not only for the cancer treatment. Whenever the patient is landing up into bone metastasis, so obviously this will be carried out. So along with this, what else we are trying to talk about? We are trying to talk about follow-up and survivorship. So survivorship is very, very important. It's just like an female, survivorship, what we do for, CA breast and CA ovary and so many, cancers. Same likewise, even we should also have a survivorship program for men who have been diagnosed with cancer, because it's very, very important. The reason is these particular people play a very vital role in sensitizing and asking the other men to break the myth and come forward. So sometimes it is also more about a kind of an image disturbance for a man to come and say that, yeah, I'm being affected now with the CA breast. So probably a men think, okay, now everybody's going to make fun of me, right? So probably those things are also prevailing among our men, because our society has given a more of masculine nature, or an appearance for the men, and always men do not cry. That is how our society is always thinking of. So most of the time the reporting also becomes a problem. So it's more important that we have a survivorship program or survivorship group, where the affected men who have been already on a treatment and who have been on a already a warrior, we could see, who has already succeeded cancer, they become the brand ambassador to talk about cancer in men. That is very, very important. We are trying to talk about, and we can also have a overall idea or overall counseling and the preventive aspect given on genetic testing. Nowadays, lots of genetic testing, and the panels are already been available. We have 500 genes testing, we have 532 gene testing, we have 580 gene testing. So there are different, based on the affordability, based on the the predisposing factors of the family. A doctor can choose what type of a gene testing can be done. It can also be done for our own family. It can be for our kids also. Probably it can be like a preventive check, what we're trying to do. It can be done for everybody. It can be done in the entire family. If at all a grandmother or grandfather or our parent or an elder sibling is affected with something, it should tick us that probably tomorrow it's me, or tomorrow it may be my kids who can be trying to carry these particular genes in the body. So it's more important we are able to diagnose it on an early stage, get it reported so that we are on a preventive better way. Along with this, the other cancer vaccinations also is very, very important to prevent. So coming to the case discussions, I have some 2 to 3 interesting cases which has been reported, which I was able to extract in a very short period of a time. So case one was about this 57-old man who came in, which had no history, but presented at a firm limp beneath the left nipple for 3 months and no pain or discharge. Okay, so basically FNAC was done and all those things, and then it was diagnosed to be having an invasive ductal carcinoma, which was having an estrogen receptor positive and HER2, that is human epidermal growth factor, HER2 was positive. So basically, this is a test which has been done to understand whether the patient requires a hormonal therapy or a chemotherapy. So any breast cancer we are trying to talk, it can be men or women. These are the basic blood tests which has been done: PR, and HER2. Right. So what was the treatment given here? Surgery was being performed. Along with that, we also underwent a tamoxifen and a radiotherapy, overall as an oral tablet for 5 years. And, the patient was, living, or still he's living, I'm not very sure, for almost around 8 years. And, he's on a follow-up. So what is the key learning here was early diagnosis. That was wonderful that a patient came in early and the patient was able to be identified, and a patient was having a hormone positive. So it became more easy for a patient not to just be in the hospital, or not to have more about of losing of a hair because there was a chemotherapy given or something like that. It was more about a simplified treatment. Nobody knew it. He just came, he underwent a treatment. He was diagnosed, discharged to the home within 1 week, and then he started taking an oral tablet. So it was more easier for him to sail this particular process of diagnosis to the treatment to the kind of successful journey of coming out from the disease. The reason was it was not more about of a chemotherapy where publicly the entire society was coming to know and all those things. So it was more of that factor also, where we could say a patient was able to succeed more. And the case two was all about locally advanced disease, where very locally the disease was advanced. We were trying to talk about the 64-year-old, some automobile mechanic who came up, a chronic smoker and alcohol, and he was also having the painful kind of a lump which was there. And the diagnosis, again, it was invasive ductal carcinoma. Here you could see the ER was positive, PR was positive, and HER2. Okay, so all these things were HER2 was negative, and it was diagnosed elsewhere. The reports were with us, and then we started going with the treatment because HER2 was actually negative. So obviously we have to go for chemotherapy. So it was a neoadjuvant chemotherapy, anthracyclines with taxane, paclitaxel, and all those things, and then modified radical mastectomy with accelerated dissections, and adjuvant tamoxifen therapy with a follow-up of 5 years. So this was one of the case. Again, we were trying to talk about as an locally advanced case, again, which is kind of okay and surviving good. And third one is the metastatic bone cancer, where the patient had already got spread. So this was a 72 years old man, but probably this particular person was kind of a neglected person, and who came in with the liver cirrhosis history also, with enlarged breast lump and all those things, bone pain, all those things. And where we tried to diagnose, it was all about HER2 was positive, invasive ductal carcinoma. Then again, the patient was supposed to be started on systemic therapy with trastuzumab and paclitaxel. Systemic therapy is nothing but IV chemotherapy. Rather than having an oral, it was an IV chemotherapy, later maintained on trastuzumab and tamoxifen. Trastuzumab is nothing but a targeted therapy. Earlier we discussed about this, a targeted therapy, right? So this was a thing, and tamoxifen and hormonal supplement or a therapy. Along with that, the bone metastasis was managed with the bisphosphonates. Otherwise, the market name is nothing but zoledronic acid. Bisphosphonates were given. Okay, so this was again a thing, and this was a failure case where we were not able to kind of have this particular successfully a patient surviving or living. This was a 63-year-old patient, but the mother had look into this family history. The mother had breast cancer, and this particular person actually was not very clear whether it was a breast cancer, but the patient reports say, the history collection told that she died because some problem was there on the upper chest. So it was considered to be as a breast cancer, but not very clear whether the mother died of breast cancer or there was a history like that. Okay, because he was already 63 years and he was not kind of very sure what exactly it was. And then the diagnosis were made. Hard mass was there, axillary lymph node was positive, and again invasive ductal carcinoma where ER positive, PR positive, and HER2 negative was there, and it was already 3A with tumor third stage. Node was 2, and metastasis was on a verge of kind of in 0. So there, the treatment again was the same thing, neoadjuvant chemotherapy, which was put on AG regime. So AG regime didn't actually work on properly. It was kind of a partial response was there, and then they had to go for adjuvant therapy with radiation, radiotherapy or radiation therapy with the tamoxifen. Along with that, surgery was also performed. So progression was after 18 months, bone and liver metastasis was already found because liver was already having a problem because he was having a cirrhotic liver. So it didn't work well. Probably this chemotherapy will work much better when our livers are, all the other systems are working better, because there's always a mechanism of absorption, excretion, and removal of the waste materials also. So usually the liver also gets affected more in when we are trying to talk about a person having a cirrhotic liver and then going with the chemotherapy also. So apart from this, it was also started with letrozole with palbociclib, that is a targeted therapy, and then a palliative radiotherapy and bisphosphonates were put in, but outcome was not great. And after 27 months of diagnosis, the patient died in the same hospital. Out of that, we were not able to achieve a great success of cure for the patient. So this particular case histories are not to threaten, not to tell that okay, when it is going to be a male breast cancer, it can be curable, it is not curable, sometimes the patient may die also. It's not about that. It is all about trying to talk about how early we are able to diagnose and how early we are able to help our fellow brother, a father, or self, getting diagnosed much more, if at all we are able to understand my body is not this, my body is having a change. So basic ideation or idea behind all these particular webinars is just to make you all understand that having a conscious sense of my body and my skin, it's very, very important. When I, at least in a month's time or on a daily basis, it's good. But if at all we are in a situation where we are not able to perform, at least on a weekly basis or a monthly basis, once you are supposed to stand in front of a mirror, looking into your own skin to understand, is my skin, what is my skin, what is the color of my skin, what is the shape of my body. If that is not done, we may not know what is the changes which is going to happen the next month or the following month. That is the reason why most of the time we get reported very late, where there is no cure. That's the reason why till date we are trying to understand cancer is non-curable. It is a kind of a chronic disease, or it's kind of a dreadful disease. It's not like that. Cancer is definitely a curable disease when it has been diagnosed in the right stage. So how do we diagnose in a right stage or an early diagnosis? It is when I have an understanding better about my own body, own self. I'm able to understand my body is not this, I'm having a change. Let me go consult a doctor. That's very, very important. So thank you so much for Nurseslab for giving me this opportunity, and to all the participants who have connected here in this evening. Thank you so much for your attention.
Thank you, sir, for the extensive study presentation on breast cancer in men. I'm sure it was very informative for all present here.
Thank you all. Thank you so much. Thanks, Nurseslab, for the opportunity. Thank you.